Good evening, everyone, and welcome to another Salty Dog webinar. I'm Alex Helfand, Education Coordinator for the Salty Dogs, and I'm really happy tonight to introduce Alex Cullen, who's the Director of GW Maritime Medical Access, and introduce all of you to the first of a five-part series that we've put together on emergency medicine at sea. I think it's a really important topic. We're not going to make you doctors, we're not going to make you EMT specialists, but I think we're going to give you a lot of useful information that will have you be better prepared for the worst stuff that could happen out there. And I'm not going to say much more than that. And I'd rather let Alex do all the talking tonight. And with that, I'm going to turn it over to Alex Cullen.
Thanks, Alex. Good evening, everybody. As Alex mentioned, I am also Alex. We just wanted to make it easy for everybody to remember our names. I'm the Director of Maritime Medical Access, an avid sailor myself, scuba instructor, a flight paramedic, and a critical care paramedic, going on 23 years on an ambulance here. And I work with GW in Washington, D.C., where we manage a maritime medical access call center. What we do is take phone calls from everybody from the Salty Dogs to the Antarctic Base Station, and help them through medical emergencies in austere environments or resource-constrained environments. So I'm really looking forward to this partnership. And as Alex alluded to, it's going to be a five-part series, today being the first installment of many. So tonight we're going to be discussing cardiovascular and respiratory emergencies. And then again, March 4th, we'll be going over skin and burn related things, musculoskeletal problems on the 25th of March, seasickness and GI issues on the 15th, and sailing and aging considerations on May 6th. At the end of the presentation, there's an evaluation of both me, the content, and what you'd like to see in future webinars. Again, I think Alex and I have been talking about this for a while, and the goal is to put out the content that you guys need and in a format that's digestible to all of you and that you can come back to if you need be. In that evaluation is also a comment box for anything, whether it's a question about an experience you've had in the past or how to troubleshoot a specific situation. Again, feel free to put any of that into those comments so that we can get you an answer. We'll sort of jump right into this. Unfortunately, we are going to talk about some of the most serious medical emergencies at sea first in this webinar series. And these are two quotes that I think really drive home the rationale for why we started here. So acute cardiac events are across the maritime world, whether it be yachting, cruise ships, professional maritime fishing, any industry. In every category, they are the leading cause to a medical consultation or, at worst, an evacuation or mortality. And there's a number of reasons for that. The rationale is, A, that we are far from land. We don't necessarily have the best access to care. One is that we're frequently in stressful environments, and that we may be concerned about the vessel, the crew, the route, the weather, and frequently not ourselves. And so ultimately what we're going to talk about tonight in terms of cardiovascular issues is the sort of big five problems that we see, as well as how to spot them, what to do if you think you're experiencing or someone on your crew is experiencing any of these things, and then what we can do to be prepared in the long run, whether that be having appropriate things on board the vessel or at least knowing who and how we can reach out to try and troubleshoot those. Inevitably, there's going to be a difference between what's capable on your vessel or the yacht that you're on and what we would do in a hospital. And so I don't want to spend too much time talking about how to fix these things in the hospital, but I am every once in a while going to explain that this is what we would do. And the reason for that is that not all medical facilities are created equal. For example, when we talk about going ashore for treatment, It may be that you're going ashore to a clinic that has the ability to sew somebody up, but not the ability to do an EKG. And so we'll also talk sort of about that difference. When we talk about cardiovascular issues, this is the list and breakdown of how these impact seafarers specifically. We'll talk about all of these in specific, but I do want to sort of highlight the fact that more than half of these things fall into this vague category of acute coronary syndromes. And we'll talk about what that means a little bit more. But a lot of folks would hear the word heart attack, and that's sort of the synonym there for acute coronary syndromes. Again, more than half of these things are going to be in that category. And our concern there is really that a heart attack can look like a lot of different things. In order to understand what's going on with a person, I put up this sort of relevant histories checklist. And these are sort of the questions that in any medical emergency, it would be relevant to answer so that we could help nail down the most likely cause of that problem. On the left, we have the sampler model, and this is just the idea that if you collect these 6 pieces of data, we can typically use them to refine down our diagnosis and either rule in or rule out one of the problems that we're going to discuss this evening. Just to go through them one by one, when we talk about signs and symptoms, we're looking at what you can see and what the person's experiencing. So we care about how they're feeling, their pain, their difficulty breathing, but we also care about what their skin looks like and whether or not it looks like they're comfortable. We care a lot about allergies, especially if we're going to give anybody medication, but we also care about allergies that could be in the environment around us. And so those are going to be sort of 2 separate pieces to evaluate. We care a lot about medications, and not just medications that we are prescribed, but also over-the-counter remedies, things we take on a regular basis, whether that be vitamins, hormone replacements, herbal supplements, anything like that. All of these things have an impact on our health. And so understanding what people are taking is going to be quite helpful. Past medical history is always an interesting one because the older you get, the more you have. And so what I would say is we care about pertinent medical history, and that includes surgical history as well as any sort of medical problems that you've dealt with in the past. The reason for that is that if you've had breathing problems in the past and you start to have a problem, it's most likely another breathing problem. And again, if you've had heart problems in the past or blood pressure problems, then you're more likely to see further development of that problem rather than sort of the onset of a new one. And so we care about your medical history both so that we know what we're dealing with, and we also understand the context from which you're describing how you're feeling. Your last oral intake is important. I think the best example I can give you here is probably once a week, someone comes to the ER and says, I'm peeing or pooping blood. And we ask them what they had for lunch, and they say a beet salad. And so we care a lot about what you've consumed, because if you have food poisoning, then we want to know what you ate, but we also want to know if everybody else on the crew had the same thing. If you are having sort of abnormal bowel movements or a discoloration or smell to your urine, or if you're having any sort of vomiting, again, we want to know what made up this scenario that we're looking at and talking about here. In the setting of a person who's lethargic without any energy, we also want to make sure that you're eating and that we're not dealing with somebody who's, not been able to keep food down. The E for events leading up to is sort of a quick vignette of what happened. I was taking a nap and I woke up and all of a sudden I had this crushing pain in my chest, versus I was pulling up the main and I was really working hard because the winch wasn't working. And so, I had to haul on it. And by the end of it, I ended up with this squeezing pain in my chest. Those are 2 very different sets of events that are going to help us understand what we think the most likely cause of that symptom or sign is. And then risk factors, this is going to be your modifiable and non-modifiable risk factors. Things like diabetes, hypertension, obesity, a lack of cardiovascular fitness, smoking, drinking, all of the things that we have that might be true in our lives that are going to factor into either an increased risk for a problem or an alternative presentation for one of these medical emergencies. On the right-hand side, we've got a section of the alphabet that we use, the OPQRST set here. And this is really to help us understand pain in general, but it's super helpful when we're dealing with any acute pathology as well. Onset has a very similar vibe to the E in sampler. This is like, what were you doing? Was there exertion? Was there specific exertion or range of motion? Again, when we get into musculoskeletal injuries, that'll be super helpful. The P stands for provocation or palliation. Simply put, what makes it better or worse? Again, sometimes people have this, well, what makes it worse? Well, it's worse when I do this. Well, we then stop doing that, right? We want to know what you can do to make it better or worse, because that's going to help us understand, A, how to make you more comfortable, but B, a little bit more about that pathology. Q is for the quality of pain, whether it's dull or sharp, whether it's constant or intermittent, whether or not it occurs to get worse with breathing, or whether or not, it's just like a throbbing discomfort. Anything that you can get the patient to do to describe their pain in their own words helps us narrow down which system in the body is reporting that pain. Radiation is a silly medical word for, is it moving or is it anywhere else? It turns out we were all born and our nerve system was balled up. And so every once in a while, you can have pain from your liver and feel it in your shoulder, or you can have pain from your heart and feel it in your jaw. And so asking people to describe not only the pain that they initially complained of, but also if they felt it moving anywhere or they felt it in any other places, can also help us try and nail down topographically where this could be coming from. Severity, this is not about your pain tolerance. This is about relative comparisons of your pain over time. So it doesn't matter to me if somebody says this is a 10 out of 10, even if I don't think it is. The question here is your pain getting better or worse? Again, I think it's worth explaining, from 0 to 10, where 10's the worst pain you've ever felt. Again, you'll see some people rate their pain and it's always a 10. Some people rate their pain in the mid 5s all the time. But either way, we're using this to track that person's pain in this instance over time. And so long as they use the same scale each time, we're getting a good measurement. The last thing there is time, and that's, when did this start? A lot of medical pathologies we're going to talk about today will either get worse or get better with time. And so understanding what time 0 is, when this sort of started, that's going to help us try and understand sort of next steps. So what is an acute coronary syndrome? It's a heart attack. And we'll talk about the difference between a heart attack and a stroke and a cardiac arrest here in these next couple slides. But a heart attack is when you have a blockage in one of your blood vessels that's creating a lack of delivered blood flow to meet the demand of that muscle, right? Your heart's just a muscle like the rest of them. And so as it works harder, it needs more blood. And so when we talk about heart attack, what we're talking about is either that a big clot floated into the blood vessel and blocked the whole thing, or that there was a narrowing or plaque buildup from genes, years of bad diet, or just pathology that you have. And the clot only then has to take up the remaining space. So you can have a heart attack that's just caused by a clot. You can have a heart attack that's just caused by a plaque, or you can combine those two things and end up with the same piece. It's kind of like when you turn off a diesel motor. You're really just choking out the fuel to the engine. And if you pull the kill switch all the way back, it kills the motor. If you pull it back halfway, it starts to starve the motor. And the same thing happens to your heart in these situations. So what can we do? How do we know if somebody's having a heart attack? That's really, I think, the most important set of questions we can ask ourselves here. Um, the first part of it, though, is to understand the symptoms. And so we want to try and get this person to calm down and stop exerting themselves. That's going to decrease things on the demand side. If the heart doesn't need as much oxygen because it's not working as hard, even though there's a blockage, the blood flow getting past it could be sufficient to prevent damage or ultimately death of that cell. Um, so a lot of people complain of chest pressure or chest pain. They describe it as in the middle of their chest. It turns out your heart doesn't have the ability to feel pain the way your skin does. And so people can't nail it down to like right here because your pain sensors in your heart don't have that resolution. So one of the questions I like to ask people is, can you point with one finger to where it hurts? And if they say no, it's a cognitive bias that we have to try and answer questions with a yes. And so it forces them to say, no, I can't do that because it's in here. That gives me a really good understanding. We're probably not dealing with a lung or a musculoskeletal problem. We're probably dealing with a cardiac problem. I think it's also worth noting, and I think you guys can see me, but like we have our heart, our I Pledge of Allegiance heart, and then we have our sort of real heart that's sort of in the middle of the chest right here. And so in a lot of movies, people are like, oh, my chest hurts. In reality, it's right in the middle that we would see people sort of grabbing at their chest like this. And it's so common that it's actually got a name in medicine. I think a lot of folks describe sort of a deep or squeezing or a tightness in their chest. Some describe it radiating or moving to their jaw, their shoulder, their neck, their back. But I do think it's worth understanding that statistically, you're the most likely to survive a heart attack if you are a white, middle-aged married man. And that's because we studied heart attacks in white, middle-aged men. And so this constellation of symptoms that I'm describing of like left-sided chest pain going to your jaw and your left arm is most common in that group. The spouse portion is just because they make you go to the hospital. But again, when we talk about how this works, you could end up with epigastric pain or pain in your upper abdomen. You could end up just with difficulty breathing. And we'll talk about how all these systems sort of relate to each other and why these symptoms can be so disparate across different types of people. I think it's also worth noting that diabetes and age can change the presentation of an acute coronary syndrome. And so, again, what we tell people is that if someone's complaining of a squeezing, dull pain or sort of just feeling off between their neck and their belly, that we want them to stop exerting themselves so we can see if that goes away. Again, back to the supply and demand side, what we're going to do is have these people rest so that we can decrease demand. Excuse me. And if that doesn't work, we could try and give them oxygen. Now, I can tell you as a cruiser myself, getting tanked oxygen in other places is one of the more difficult things, even for cruise ships. So having oxygen on board is not a commonplace thing on board a boat. It's a great tool to have, but it's logistically complicated. With that being said, aspirin is cheap, ubiquitous, and very easy to store and transport. And so I think on board every boat should be chewable aspirin. If someone's experiencing any of the symptoms we just described, you can have them chew up some baby aspirin. And so long as they're not allergic to it, it really should have almost no consequence if they're not having a heart attack. I like treatments like this because they allow us to do good things without any consequence. If you have a person on board your boat who's had chest pain before or a history of heart problems, they may be prescribed something called nitroglycerin. And this is a medication used to treat chest pain. The way the medicine works is it makes your blood vessels get bigger. And so if you had a 75% blockage of an artery, and we made the artery 10% bigger, we might end up now with only a 60% or a 65% blockage, which might be enough flow to meet the demand of that heart. And therefore their pain will go away. And now we've just got to keep that person resting until we can get them to a better evaluation. I think it's worth understanding how to take a set of vital signs. That's going to be a heart rate, a respiratory rate, a blood pressure. If you have a pulse oximeter, that's the little thing that goes on your finger and measures oxygen. These numbers are going to help us figure out if somebody's getting better or worse. These numbers are also going to give us an idea of whether this is normal for them. One of the things that I like to recommend to people before a cruise is to have an idea of what your normal blood pressure, heart rate are, so that if you have an abnormal reading, we know what your baseline was. Again, in a lot of these situations, there's fear and stress, and those things can artificially elevate your vital signs as well. I think anybody having chest pain on a boat, this is one of those moments where the best thing to do is reach out to assistance if you have the ability to. There's a saying, it's as serious as a heart attack, and that's because it can be a very serious medical problem. With that being said, I do think it's worth highlighting not all heart attacks lead to death. What they do lead to is a part of your heart not working as well as it was prior to. And so obviously that can be a problem down the road. Some heart attacks can lead to cardiac arrest, and that's really just going to be if the part of your heart that died was the most important part or the biggest part, the left side, then a heart attack is going to be more problematic than if it was a smaller part of your heart or the right side of your heart. And that's just because of the different chambers and their jobs. If somebody does have a cardiac arrest, we're going to verify that they're pulseless and not breathing. We're going to start chest compressions. Ultimately, I feel like as folks that are out on the water, we should be trained in CPR and proficient in these skills. I don't necessarily think you have to keep a CPR card current, just to make sure that you're proficient. I personally think keeping a CPR card current is a good idea, but I understand that, maintaining those can be difficult. One of the things I want to highlight about CPR real quick while we're on the topic, though, is that a lot of resources out there say you don't have to ventilate the person. You don't have to give breaths. That's true on a city street where there's an ambulance driving down the road to take you to a hospital. The problem with that advice in the cruising world is that the ambulance is never that close, and the hospital is always a little further away. And so just understand that the reason that that statement is made is because at the time someone has a cardiac arrest, there's some oxygen in their blood. And so not breathing for them is okay because we can circulate that residual oxygen. In the setting of being on a boat at sea, you're going to run out of that oxygen relatively quickly. Even if you're 30 minutes away from the dock, we're going to need to breathe for these people. And so having a way to do that, either by mouth to mouth or with a mask or some other barrier device, is a worthwhile thing to have on board every vessel. Okay. We're going to talk next about clotting issues. So we talked about acute coronary syndromes and what we can do. Again, for us, we're going to give them oxygen if we have it, force them to rest. Even if they want to help, we're going to try and keep them as calm as possible. That could be a sort of an acute problem. The next thing I want to talk about here is clotting issues. The first part here in part one, we're going to talk about something called a deep vein thrombosis, frequently called a DVT. This is when a blood clot forms in a blood vessel of the body and blocks blood flow back to the heart. What it's going to do is cause all of the blood vessels in that limb to engorge because the blood flow can't come back. And so you see in the actual photo here, the limb on the right is more red than the one on the left, and that's because it's more full of blood. If you could actually put your hand on those legs, what you would feel is that one of them is taut and more engorged, and the other one feels supple and normal. And so again, anytime you have a color difference between left and right, anytime that you have a sort of a feeling difference between left and right on your limbs, you should be concerned for that. In medicine, we frequently say that symmetry is normal until proven otherwise. And so the good news about a DVT is that it starts out as just a leg problem. And if it's caught early enough, it can remain just a leg problem. I think it's worth understanding that these are more common in folks that aren't walking as far. And so we see a lot of them on crossings and in cruisers, because it turns out if you've got a 15-day sail, you're probably not walking a mile a day. And so again, this is the same thing you might hear on like a long haul flight where they say, you know, remember to do your ankle circles, or you hear about people wearing compression socks. All of those are just attempts at decreasing the amount of blood that can pool in your lower extremities. The worst case scenario with a DVT is that a piece of it breaks off. And if a piece of a DVT breaks off, it can actually float up into both your lungs and potentially your brain. And so that's where we're going to run into something called a pulmonary embolus, or a pulmonary embolism. These are bad because now the clot's not just affecting your leg, it's affecting your whole body, and it's affecting your life support system. So while the DVT was painful and uncomfortable, this is producing shortness of breath and chest pain, and potentially can sort of create a kink in your circulatory system. Anybody at risk for DVT is also therefore at risk for PE. A history of having these clots makes this significantly more common. If someone was taking anticoagulants or blood thinners and for any reason stopped taking them or ran out, they would be at an increased risk for these clotting issues. But here you're going to see, instead of like a dull, achy chest pain, you're going to see a sharper chest pain. Again, because the lungs have more resolution to feel pain, they'll be able to tell you where it is on their body more specifically. And they frequently will also say that it's worse with breathing. That is, when they take a breath in, they feel it more than when they breathe out. So again, these are sort of two issues with our vascular system that I think are noted and worth paying attention to, understanding what they look like, and understanding that if we see these things, we need to try and get help. It's always worth asking if somebody has a history of atrial fibrillation. This is one of the more common heart abnormalities in the world, and it increases in likelihood with age. The problem here is that it creates the ability for blood to clot more easily, and as a result, you have a higher risk of a PE if you have AFib itself. When we talk about stroke, we're looking at effectively the same thing. Your heart is a muscle, it's pretty durable, it has a lot of different options for blood flow. Your brain is a very sensitive neurological organ, and so ultimately the same blockage, whether because of a clot or because of plaque, can create a lack of blood flow in the brain. And if it's not sufficient to meet demand, what we start to see is problems with that function of the brain. So if you have a stroke in the back of your brain that processes vision, you'll have visual problems. If you have a stroke in the front of your brain that controls behavior and speech, then you'll see those changes. And so it makes stroke very difficult to describe because it can look like so many different things. The simplified problem here, though, is that wherever that blockage or leakage in a blood vessel is, everything beyond that or downstream of that interruption in blood flow is not getting an appropriate amount of oxygen. And as a result, this is a life-threatening emergency, and at a minimum, it's a brain-threatening emergency in that location. Ultimately, slurred speech, facial droop, and weakness on one side of the body are going to be the most common symptoms, as well as an altered mental status. I did allude to the fact that strokes come in two varietals, and there's a clot-based stroke, which is exactly the same as the heart attack we just described. And then there's a leakage or a bleeding-based stroke. The reason I bring this up is that this is why I'm not telling you to chew up an aspirin now, and I did just a minute ago in the heart. And the rationale is that 87% of the time it's a clot, and the aspirin would help. But 13% of the time it's a bleed, and the aspirin would make it worse. And so that's a risk that we calculate frequently in maritime medical access with folks on the phone based off of how far out they are from a facility that could manage that person definitively. There's a lot of references out there that talk about like the faster mnemonic, and that's again just trying to understand whether or not we have deficit in the neurological systems that could be caused by an interruption in blood flow. Okay, so these are my last two cardiac pieces to talk about here, and we'll go through these in sort of specificity. If you think about a heart attack, like we talked about, it was a part of the heart dying or being injured. If you injure a little bit of your heart, eventually your heart will not be as efficient as it once was. And just like any other pump, if a pump isn't working as well because it's cavitating or the head pressure is too high or the intake is clogged, all of those things are going to create inadequacies in flow or excess pressure. And ultimately, when the pump we're talking about is your heart, you start to see those changes in the body. So again, if you have a right-sided heart problem, you might end up with swollen feet. If you have a left-sided heart problem, you might end up with fluid in your lungs. And so when we talked about swollen feet from a DVT and we talk about lung stuff in a little bit here, it's going to be important to understand that a heart by itself is nothing more than a pump. It's just unfortunately responsible for pumping the fluids that keep us alive. And so again, if we see problems with that pump, we're going to have to try and evaluate and track that person's vital sign status. It's also worth noting that if somebody has a history of heart problems, they may have some pre-existing degree of heart failure. And so again, this is a part of the conversation we're going to have at the end here, where we can talk to our crew or the people that we're cruising with and say, hey, listen, like I need to understand the medical problems you have so that if something were to happen, I can accurately communicate your medical history if you're not able to. And again, we'll talk about some strategies for how to safeguard that information because it is private, but also to have it accessible so that we can make decisions based off of the most informed perspective. Again, I think when we start talking about long distance sales, it's also worth trying to understand how we can get exercise while we're on those cruises. It turns out that, the first time you walk up some stairs after you've been on a boat for a long time, that whole flight of stairs is all of a sudden a little bit more tough than you thought it would be. And that's just because you haven't had to do that over the period of time. And again, we lose cardiovascular fitness much quicker than we gain it. I think this is less of a problem at anchor or while we're sort of sitting in a specific destination, because you can get a good amount of cardiovascular fitness from swimming and moving around. But when we're confined to a cockpit and sort of trying to stay safe on a cruising, you see a lot less movement. On the right-hand side of this slide is just the word arrhythmia, which just means a weird rhythm. So it turns out that your heart has a very specific rhythm it's supposed to be in. And if we have any disruptions to that, we can see problems. It turns out, just like any pump, if it's too fast, it'll cavitate, and if it's too slow, it won't move enough fluid. And so ultimately, the same things are true with the heart. Again, when we see heart rates that are too fast or too slow, we either have to try and speed it up or slow it down, or at the very least understand why it's doing that irregular rate piece. Atrial fibrillation, number one heart arrhythmia out there. It decreases your heart's effective output by about 25% when it starts. And so again, we hear these folks in the hospital come in all the time and say, yeah, I was fine this morning and now I get winded when I walk to the kitchen and it doesn't make any sense. And it's because they've decreased their cardiovascular fitness by 25% in an instant. It is treatable and can be managed with medications or procedures, but again, it's going to produce an irregular heartbeat. So instead of like a boom, 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 you're going to have a boom, 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 boom. And that irregularity creates turbulence in blood flow. This is my opinion. 35 and over, you should get an EKG and you should save a picture of it on your phone, because if you ever have a heart problem down the road, one of the questions we're going to try and understand is what's normal for you. And so again, I think the next time that you see your primary care doc, you should have an EKG conducted and take a picture of it or a copy of it and save it, so that if there are ever problems down the road, you've got a baseline normal for you that we can compare things against. That makes that second EKG on the X or when we're having problems infinitely more valuable. Again, anybody over the age of 35, I think it's imperative that we have a pre-cruise evaluation or an annual physical at a minimum, where we're having our labs checked and we're sort of just trying to make sure that we at least understand the medical problems that we're potentially facing. I'm a big fan of having some form of getting an EKG on the boat. In this day and age, all you need is somebody with an Apple Watch. And even if it's not yours, you put it on your wrist and you touch that side of the thing, and we can hopefully get at least a rudimentary EKG. I don't think you need a whole heart monitor on board, but now that there are so many options for doing this with a wearable, I think it's a fantastic tool. We've had some really good outcomes with folks in the yachting and fishing communities being able to transmit us an EKG where we can actually interpret the rhythms for them. I know this is a lot real fast, so if there's any questions, I didn't see any in the chat, but
Actually, we do have a couple.
what do we got?
Let me help you with that point. So we'll go, let me just go to the top so we don't leave anybody out. Okay, there was a question just about medical evacuation insurance and such. We're going to talk about that in another session, so just hang in there on that one. This AI assistant seems to want to help us. I don't know who he is. Why did you not mention defibrillators in the section on heart attacks? So that's a question.
Yeah, so ultimately, I think defibrillators are a fantastic thing to have on board a boat, but I think the vast majority of people don't have one. If you have CPR training and a defibrillator on board, 100% it should be put on anybody who's in a cardiac arrest. I think my perspective is that the vast majority of cruisers don't have a defibrillator on board, and so I think it's an omission that certainly could be put in there for a more complete history. But by all means, I believe they should be used whenever they are available. Again, unfortunately, we don't see many instances where there's a defibrillator on board.
Okay, I thought I read that, in some cases, having a defibrillator on board is great, but only if you've got emergency medical care close at hand. And if you're days away from help.
I would say in the perfect world, everybody should have a defibrillator on their boat. The problem is they're $1,000 and the pads expire, and in some states you need a prescription to have one. And so they're logistically complicated. They're electronic. And so, I think it would be great to have a defibrillator on the boat. It's another piece of kit with a single functional use that costs a lot of money. And again, you could luck out, deploy a defibrillator successfully, and save somebody. In most instances, even a successful defibrillation is not enough to bring somebody back without a good amount of other things on board. And so again, I think there's definitely a benefit to having one if you have the space and the logistic support and financial support to have one.
Okay. I had a question. You were talking about swelling in your legs, and
Yeah.
you mentioned lack of activity versus other, venous
DVT?
thrombosis stuff. Yeah.
Yeah,
Um,
so if you're swollen on one side, that should be much more concerning to you than if you're both swollen. I think we've all noticed the like swollen ankles after a few days at sea, and that's pretty normal. If they're better in the morning than they were before you went to bed, it's also typically not a DVT, because the DVT is going to be caused by a blockage that doesn't change with position. Whereas being on your feet on a hard gel coat surface, it's going to give everybody a little bit of lower leg swelling, but it's typically going to be in both of them.
okay. I assume it could be worse in one than the other, but you'll probably see it in both. They don't have to be even.
Correct.
Okay. Cora had a question. If you suspect DVT, what measures can you take to keep the piece from breaking off and traveling through the body?
Yeah, so ultimately, the you would want to try and minimize movement, but ultimately, even sitting perfectly still isn't going to guarantee that a piece of that clot can't break off. And so we want to try and minimize exertion and movement in that person until we can get them to a place where we can get that clot out, either by pulling it out or medically dissolving it. But again, there's not a ton that we can do in that situation to prevent it from moving.
Okay. And Babs had a question. Is there a test for plaque buildup, maybe to
Yeah,
know that you've got a problem?
yeah. So you can see these with either what's called a stress echocardiogram, a calcium scoring test is another version, or different type of test. There are tests that will evaluate for plaque buildup, but ultimately, most of them would need to be ordered by a cardiologist. It's not like you could go to your doctor and just say, "Hey, I'd like this test." They typically would have to be ordered at a specialty clinic. Um, Ultimately, it's probably something that is worth doing at some point in your 40s to 50s. And then from there, there's a trajectory of sort of what we think this looks like.
Okay. Um, there's a request to maybe go back to the faster stroke, the slide that talked about the stroke diagnosis.
Okay, I can do that. I just got to figure out how. And then the last question here, women often get significantly different symptoms. So yeah, the number one presenting symptom in women is typically epigastric pain or upper abdominal pain. And this is why we see heart attack recognized less effectively in women, is because if I say I have chest pain, everybody assumes heart attack. But if I say I have indigestion or pain in my upper abdomen, a lot of people assume indigestion or an upset stomach. And so again, we sort of need to look at like problems between the chin and the navel as being a heart attack until we can prove to ourselves that they're not. I don't want everybody to ramp up to a DEFCON 1 because someone's got an upset stomach. But the way that I look at things on the ambulance, or when I interact with people suffering a medical problem, is that it took them some gusto to decide to complain about this to me. And so instead of trying to figure out what they have, I try and figure out what they don't have. You take the whole list of all the things that could be causing their problems, and one by one, you cross them off of that list as you find out that it's not that problem. And again, I think you see difficulty breathing, nausea, and upper abdominal pain as frequent symptoms in women. And again, especially women over the age of probably 60 to 65 as the number one presentation there.
Okay. Were we going to talk about that faster slide for a moment? I don't know if they wanted more elaboration. There it is.
Ultimately, so the math here is that your face, if you have uneven changes in your face, that's typically a symptom of a stroke. It could be a couple other things, but anytime you see changes in one side of a person's face, we win a high index of concern there. The arm thing is interesting. Really, there's two parts to it. One is that someone might not be able to move an arm well. The other is if you have a person sort of stand like this with their palms up and they close their eyes. When you have a stroke, your brain doesn't know where your other limb is in space as well. And so when they close their eyes, what you'll notice is one of their limbs will start to drift away from the other one because their brain's not aware of where it is in space and it can't maintain that position. Stability, again, like I don't want to make somebody walk, but that same thing that's making one of my arms move is going to make it harder for me to walk around. And so you might see an unsteadiness in their gait. Again, on a moving boat, that's going to be hard to ascertain because all of us look a little clumsy if we're taking waves. But again, if it's atypical for that person, then again, that's a concern. Slurring of speech. I think it's important that sometimes people slur their words because their mouth isn't working as well. This is what you see in folks that are too intoxicated, for lack of a better example. You also have folks that struggle to pick the right word. And that's that they're speaking or they're phonating appropriately, but they're having trouble picking the right actual word. So they'll struggle to say like the word cup. They'll be like, what is this? I don't know what this is. And it's because the part of their brain that associates things and words isn't working appropriately. That's most commonly caused by a breakdown in blood flow. And then you can also have problems understanding words. Again, if you can't speak very well, or you're slurring your words, or you're picking the wrong word, or you're interpreting things that are being said to you wrong, those are all potential signs of a stroke. And then back to my example of the eyes, the back of your brain, sort of right on the bump at the back of your head, that lobe of the brain processes vision. And so if you have a stroke in that part of the brain, you'll see visual problems, whether it be double vision, blurry vision, little things floating around in your vision, an inability to see. But if the stroke isn't in that part of your brain, you won't have those visual changes. I hope that helps.
Yep. All right. Any other questions from the group? I think this has been a really excellent presentation. Thank you very much.
Thank you. Well, we got to talk about the lungs real quick still. So,
Oh, okay.
yeah, I got 11 minutes to get through it. So we'll do the damn thing. So we talked about the heart, and it turns out the heart just pushes the red stuff around in the body. And so it's the pulmonary system that really is in charge of putting the oxygen into the blood, right? So we call it the cardiopulmonary system because you need both pieces. You need the clear stuff to go in and out very effectively, and you need the red stuff to go around and around. So we talked about pump problems. Now we're going to talk about air problems. I split this into 3 categories, just like this chart has. So you've got an upper airway problem, that's from your face to your neck. You've got a lower airway problem, that's from your neck to your diaphragm. And then you've got the lung tissue itself. And the reason that I split it up that way is that the upper and lower airway issues are simply flow problems. They are just what happens when air can't move as well. And then the lung tissue problems are gas exchange issues. And we'll talk about how that looks differently. But again, if your heart's working perfectly and you're putting no oxygen into your blood, you're eventually going to end up with a problem that looks an awful lot like a heart attack because you're circulating bad blood. And so again, we need to do both of these processes. When we talk about upper airway problems, this is stuff in your mouth and throat. And the problem here is that it's a narrow passageway and 100% of the air you move has to go through that one pipe. So it's a consolidation problem here. The biggest, scariest one up here is probably going to be anaphylaxis. This is a severe allergic reaction that causes all of the tubes in your airway to swell. The difference between an allergy and anaphylaxis is an allergy impacts you at the point where it exposes you. So if you get stung by a bee and you feel a little bump and redness where you got stung, that's a reaction to that sting. But if you get stung by that bee on your arm and all of a sudden the swelling is in your throat, that's when we know we're experiencing this anaphylactic reaction. And you tend to see hives, swelling of the face and eyes and mouth, but also swelling internally. And that's why we get scared here. There's a couple pictures on this next slide. One of them is a little grotesque. I'm not trying to freak anybody out, but ACE inhibitor-induced angioedema. If there's anybody on a boat taking lisinopril, this is one of those medicines that has a high propensity for this very strange impacted side effect, which is just massive swelling of a tongue all of a sudden for no reason. We don't entirely understand why it happens. You see a lot of folks getting off of lisinopril and onto an angiotensin receptor blocker or something else because of this side effect. Choking, I think everybody's pretty familiar with this, but ultimately speaking, choking is an upper airway problem that we would treat with the Heimlich maneuver or another clearance maneuver. And then airway burns. This is something highly problematic on board a boat because we've got a water-based cooling system. We've got potentially like refrigerants and other things that can be hot. And so ultimately, we want to be very concerned about any sort of burns to the airway. On the left, this is anaphylaxis. This picture in the top middle, this is what ACE inhibitor-induced angioedema looks like. So you can see that that person's tongue is swollen, but the rest of their face is not. That's sort of atypical. When you have an anaphylaxis, it would be the whole face and mouth. Choking, this is just a fun representation of choking. Turns out this isn't the international sign for choking. It's what people naturally do. They're trying to grab the thing. And so again, remember that choking, people can't talk or make noise. Anybody who can talk or make noise should just be encouraged to cough. And then on the right is a picture of a person with airway burns. And it's not a picture of an airway, it's a picture of a face. Because if you end up with facial burns, the assumption we need to make is that you also have airway burns. And again, the problem, same with what we're talking about in anaphylaxis and also what we're going to talk about here in a minute, is that when you swell in a tube, every facet of that tube swells, and you get actually a cross-sectional decrease that's exponential in tube size. Things to know. If we're dealing with an upper airway problem, this is all about manipulating the person's head and neck so that air can most easily flow. In the world of super inexpensive things to have on a boat, medical kit-wise, the things in the top middle there are called OPAs, oropharyngeal airways, and NPAs, nasopharyngeal airways. They are just little plastic tubes that help air flow through your upper airway. And they can be super helpful in trauma and medical emergencies. They cost like $2 or $3 a piece. They're super easy to use. I think worth having on any boat that's going out for long periods of time at a minimum. The picture in the top right is what a face looks like in cross-section. And the reason I think that's an important slide is that your airway is somewhat convoluted. And as a result, the position of your head as it relates to your chest and the position of your jaw as it relates to your neck, all are going to make that pathway easier or harder for air to move. So again, in the bottom center picture here, we have a closed airway. And by tipping the head back and lifting the chin, you can see that there's a significantly better pathway for that air to move. So these are just things to practice and understand, but also worth considering where on your vessel you could lay a person down to do this. Because again, that's not going to be the same on every boat. If you're on a catamaran, you've got a ton of space. If you're on a smaller sloop, you're going to have to do this in a different spot. And again, that's just worth considering before we get there. And then secretions. Everybody's mouth can be full of fluids, whether it be blood, vomit, or saliva. We need a way to get that fluid out of there. In the hospital, we have a people vacuum. We can, like the dentist's office, a little suction unit. But if you don't have that, a turkey baster works super well. And so again, I don't think every boat needs to have every medical device on it, but a turkey baster is like $5 or $6, and I wouldn't ever use it after it's used medically. But ultimately, again, I think it's an easy solution for a medical problem that's relatively common in an environment where you're surrounded by water. We frequently see a lot of water in people's mouths if they're ever pulled out of the ocean. or lake. And then last piece is gravity. Just understand that if this person's laying on their back, gravity wants their airway to be closed. So if we need to leave this person unattended for any amount of time, we frequently want to roll them onto their side, typically their left side. And that's just going to create some downward pressure to the left as opposed to backward, which will help maintain an open airway. And if they were to vomit while unconscious, it would spill out onto the floor and not back into them. Lower airway considerations. This is that picture I was talking to you about. So on the left, you see the normal airway, and on the right, you see what happens when it's constricted. If that's caused by asthma or burning, you're going to get that same cross-sectional decrease in area. Again, anyone with asthma should have one of these puffers on board, or an albuterol MDI. I think in the world of things worth trying to bring on boats, bringing one of these albuterol MDIs is relatively inexpensive. And if somebody ends up with a bronchitis or a bronchiolitis, sometimes these things can make that person more comfortable. If someone has really bad asthma, just like with anaphylaxis, an EpiPen can be helpful for them. And so again, in the world of like sort of ubiquitous rescue medications, I think an albuterol inhaler and an epinephrine pen are two sort of pretty ideal standards to have. Understanding people's triggers. Again, if you've got a bad asthmatic on board and you're working on something with your diesel motor, like they probably are not the ideal person to have stick their head over the side and see if there's smoke coming out of the engine. Just again, because that's something that could trigger their asthma. Bronchitis and bronchiolitis are typically viral. This is where you'd need like a Mucinex or something else to help you sort of hack out the junk. Anytime we're talking about a closed space, we want to try and make sure that we don't transmit this to anybody else. So this is a good time to try and ventilate people's cabins and try and make sure we don't pass these sicknesses along to everybody else. Epinephrine pens and inhalers you typically need a prescription for, but most primary care doctors would write you one if you explained the consequence that you were going sailing for a long period of time. In addition to which, we can talk at the end here. I'll mention there's a couple other ways that you can get some of these prescription items, to include steroids at the bottom. Also something in the United States, you would need a prescription for these items. In a lot of other countries, they're available over the counter. COPD is a chronic illness that gives you the same problems as bronchitis and bronchiolitis, as well as emphysema. And in all of these folks, it's going to be understanding where they are in their disease process and how things can change from normal. So again, if you have somebody on board that's got COPD, understanding what medications they take on a regular basis is going to be helpful to making sure that we can manage any problems we see on board the vessel. This is going to be my second to last slide. Sorry, we're going a little bit over here, but this is the lung tissue issues. This is a set of x-rays for what you will see with different lung tissue problems. And I know that most of you don't read chest x-rays on the normal, but what I do think is that it's pretty easy to see that no findings. You've got like that black, almost translucence to the x-ray. And in all of these other pathologies, what you see is a cloudiness. And that cloudiness is actually the fluid building up in the little air sacs of the lungs. And if it's fluid from heart failure or fluid from an infection or fluid, the fluid is going to impede the ability of gas to dissolve through those membranes. In a pneumonia, we need to kill the thing causing it, whether that's most commonly going to be a bacteria. In a pneumonitis, this is from chemical inhalation. And again, dilution is the solution to pollution. They just need clean air. And then in ARDS, this is folks with sort of, fluid buildup from other causes. The goal here is going to be to decrease the cause of that fluid buildup, whether it be stress, trauma, or heart-related issues. Again, I think if you have an antibiotic cache on board, having an antibiotic that can cover a bacterial pneumonia is an easy win, because that typically will also cover a number of other things, and antibiotics are relatively inexpensive. I think anytime you hear somebody like pull all the junk back into their face, just remember that the number one cause of pneumonia is not coughing the stuff out from your upper airway or sinus infection. And so again, good blowing of the nose and making sure that we're coughing out all of our secretions is a good way to avoid a pneumonia. So what can we do? This is sort of the last thing I want to leave you guys with. We can have a thorough and honest conversation with our primary care doctor and encourage all crew members to do this. I think it's especially important if you're going to be going offshore, because you're going to be far from help in a lot of situations. You can obtain medical information for the folks on board. I know that there's some concerns about sharing health information. In my opinion, the easiest way to solve this sometimes is just to have people fill out a form with their medical problems and put it in an envelope and seal that envelope. And we won't open it. We won't look at it unless we need to. So we just keep them all on the nav table with everybody's passport. They're rubber banded together. And when you get off the boat, I hand you your sealed envelope back. And I never knew what was in it, but if I had any questions and you weren't able to communicate with me, I had a way to figure out sort of what there was to know and therefore make decisions with the most complete set of information. Again, personal, I think it's worth understanding your heart rate. What is your normal heart rate? What is your normal blood pressure? All of these things are going to help us understand what you are dealing with when you're ill. Remember that pathology looks a lot like exertion without the exertion. And so again, seeing someone's heart rate that's up 20% over normal while they're sitting still means their body's working harder to do something. And that can really give us a good insight into what's going on. Medical chest recommendations, again, I think maybe one of the most imperatives is that if a person on board your vessel is dependent on a medication for anything, that they have 2 supplies of that medication and that one of them is in a different waterproof sealed container somewhere else on the boat. I think that duplicity in storage is very important. And I think I like to buy those little desiccant packs and put them in any of my backup medical kits, just so that there's no chance of water damage or sort of damage to those medications. Again, anything that somebody takes for their blood pressure, for their blood clotting, for their heart, for their liver, for their kidneys, like all of the medications that are important for life sustainment need to be in duplicate and in 2 separate places. And that way you can't have a critical issue if one of them's damaged, if a hatch is left open, something blows away. I think that's super important. And then consider, either talking to your doctor or one of your actual Salty Dog sponsors is a group called Duration Health. Ultimately, it doesn't matter to me where you get these things, but I think that having prescription medicines on board the boat, like a couple antibiotics, an inhaler, and an EpiPen, is relatively inexpensive, and it gives you a lot of capability. It avoids you having to go ashore, and it allows you to treat things and continue your adventure. And so again, I think antibiotics are super inexpensive and a lot of times can solve a lot of problems. And so I think it's worth having those access to those on board. And then the last is train, learn, read, come to webinars like this. Everything we do to try and stay on top of what can happen is all going to be helpful to us, because the more that we're armed with in terms of knowledge and understanding, the less stressful these things can be and the more intentional our decisions can be. This bottom right picture is just of an EKG. I think if everybody had a copy of their own, we'd have something to compare it to. Thank you guys so much. I put a QR code up here with a link, so you can either scan the QR code or click on the link. Either way, the goal here is to do what's right by you guys in terms of presenting the content you want and answering the questions that you have. And so again, any feedback, Alex and I would both be greatly appreciable. And I will get this slide deck over to Alex so that it can go up in your members area so that you can look at any of the pieces.
Okay, thank you very much, Alex. And yeah, as soon as you can send me the slide presentation, and this recording is being, this presentation is recorded and we'll make that available. So if you came in late or if you want to listen to it again and again, you'll have the opportunity to do that.
And
So,
I can
um,
stick around if there's any questions.
right, I am going to ask, Alex knows I'm going to ask this question. We have the next presentation in a couple of weeks is on skin um, related issues. And for those of us down here in the Caribbean, there's been a lot of chatter on WhatsApp about skin lice, I mean, sorry, sea lice. So I figured rather than wait 4 weeks or however many weeks it's going to be, we would just talk a couple of minutes about that since it's a rather irritating and uncomfortable um, problem to have. So do you want to make a couple of comments about that for anyone who's still on? We have about a number of participants here, and some of them I think are aware of the problem and probably would like to know what they can do about it sooner
Yeah,
than.
so sea lice are super unfortunate things out there, and I've interacted with them myself. And what I can tell you is that they're effectively like little jellyfish larvae that tend to be more problematic if you have more hair or more clothing on you in the water. Just gives you the ability to trap those things in against your body. And again, the idea is that we want to get them off. So one of the best things we can do is take everything off of us that we're wearing in the ocean immediately, and if possible, put it into some hot water. That's going to do the best to get rid of any of the larvae that are actually attached to your clothing itself. And then you want to rinse yourself off, preferably with some salt water first and then some fresh water. One of the things we see with these jellyfish larvae is that if you rinse yourself off with fresh water immediately, you can actually cause the nematocysts or the little stinging cells in the larva to discharge. And you can actually make things worse for yourself if you immediately rinse them off with fresh water. So we want to start off with a saltwater rinse whenever possible to try and rinse them off. Again, they get trapped in hair in between the bathing suit and your skin, so it's best to take all of the things that you're wearing off and then do this rinse if possible. And then from there, if you end up with a bunch of bites here, there are a bunch of stings. It's not comfortable. If you get a ton of them, you can actually end up with like a headache and some nausea, maybe some chills and some fever. It's relatively rare, but it can happen. Um, I think it's also worth noting that it's somewhat cumulative. So if you have it once, then the next time around, you're more than likely going to feel crappy with that same situation as your body gets used to responding to it. I think the other part of it is just afterwards, what can we do to sort of deal with this discomfort and itchiness? And hydrocortisone or calamine lotion is going to be a good one. If you're really uncomfortable, you could take an antihistamine, like what you would take for allergies. Again, Benadryl would work. Just understand that's going to probably make you tired. And then in severe cases, again, you could take a steroid or a non-steroidal like an ibuprofen, something like that could help with the discomfort. A steroid with the inflammation, but that would require a prescription. Unfortunately, there's no real way to avoid them. They're the highest in the ocean between like the April and July timeframes. And so I think local reports are going to be where it's the worst, and you probably can correlate some of these things to wind and current flows, but I don't know that there's a great model. Again, I think the odds of having them attached to you go down with the amount of clothing that you're wearing. So if you have a bunch of clothes covering you and there's more area between the clothes and your skin, you're actually somewhat more likely to get out of the water with more of these things attached.
Okay, there was a question,
Counterintuitive.
raised. They tried using lidocaine cream, um, instead of cortisone. Is that okay as well?
So lidocaine is going to numb the area more so than soothe the area if it's just lidocaine, but it should be fine. So you're not going to create a problem for yourself.
Okay. All right, any other questions? Once again, this has been a great presentation, and we thank Alex and GW Maritime Services for what they're doing. They're a gold sponsor of Salty Dogs, and Alex will be back in a couple of weeks with the next installment. So we look forward to that. Just a reminder, tomorrow night, we did have a webinar from Quantum Sales. We've had to reschedule that. We'll have that date announced in the near future. And with that, I will stop the recording and we can say goodnight.